Speaking next is Dr. Mazzone from Cleveland, our new editor-in-chief for CHEST. He's going to be updating the clinical practice guidelines for lung cancer screening.
Thank you very much for the invitation to speak today about the lung cancer screening guidelines. Guidelines were accepted for publication around 2 years ago, and they've entered a living guidelines model where periodically we're reviewing the evidence, and when the evidence rises to a level where we need to revise our recommendations, we'll be prepared to do so rather than waiting. So our current guidelines had 6 recommendations and 9 consensus-based statements. CHEST's guidelines allow us to make statements where evidence isn't strong enough for a recommendation, but where practice guidance is helpful. They also allow us to make remarks about any of the recommendations, which help us explain why we made those particular recommendations. So we did those 15 different recommendations or statements across 9 areas, and I'm only going to comment on 5 of those today for the sake of time. I'll very quickly review the evidence base that we used to make the recommendation, review the recommendation remarks, and then highlight 1 or 2 studies that may change our recommendations over time. So first is who should be screened. And we reviewed the evidence base at the time for the balance between the benefits of screening and the harms of screening. At the time, there was only 1 study that had shown a benefit to lung cancer screening of fewer patients dying from lung cancer if they get screened. And this represents the balance in that study, the National Lung Screening Trial, 3 annual low-dose CT scans in high-risk individuals defined by their age and smoking histories. There was a 20% mortality reduction, meaning 320 people had to be screened to avert 1 lung cancer death. The harms came from performing the screening study or from evaluating the findings of the screening exam. So of those 320 that are required to avert 1 death, 125 would have been told they had a lung nodule, 8 would have had a procedure, 1 patient would have been overdiagnosed and treated for a cancer that wouldn't have impacted their life, small impact of the radiation, and reasonably cost-effective. We looked to see if there was other kinds of evidence that would suggest a broader community than that screened during the National Lung Screening Trial would have a favorable balance of benefits and harms. At the time of our guideline, the USPSTF had already published their guidance. They used modeling studies of over 570 scenarios based on starting age, ending age, smoking histories, and developed this line of efficiency where the benefit to harm ratio was the highest of all of the models. The NLST equivalent was a little below that line of efficiency, and so they recommended extending the age up to 80. We looked at the 5 different models that were used to provide that line of efficiency and found that they were a little bit heterogeneous. Next thing we looked at were the use of risk calculators that use factors other than age and smoking history, such as presence or absence of COPD or the history of a prior cancer. At the time of the evidence-based guideline, there were risk calculators available that were able to show you could screen fewer individuals and find a greater number of lung cancers. However, the question that we asked ourselves was, does the use of a risk calculator identify a population equally likely to benefit and be harmed? Some of the other factors include older individuals, or they have other comorbidities that might impact the nature of their cancer or their ability to tolerate an evaluation and treatment. The risk calculators, we found evidence, if they're used, they're more likely to identify individuals who will have a lung nodule, who have increased risk from invasive procedures for nodule evaluation, more complications from resection of early stage cancer, poorer survival after treatment of early stage cancer, and competing mortality that may increase out of proportion to the increased lung cancer risk. There was also evidence suggesting it will be hard to implement those models. The 8 models were in existence and they all identified different populations, and the absolute threshold to select wasn't quite clear. So with that evidence base, our key recommendations about who to screen. First recommendation was for asymptomatic smokers and former smokers age 55 to 77, smoked at least 30 pack years, and they've been smokers in the last 15 years. We suggest annual screening with low-dose CT be offered. Age 77 rather than 74, that was the upper limit of age of the patients, the NLST, and matched the CMS policy that was already in place. We went on to say for asymptomatic smokers and former smokers who don't meet those criteria, but are at high risk of having or developing lung cancer based on clinical risk prediction calculators, we suggested that screening should not be routinely performed. And we took our time in selecting those words. We went on to be able to remark that we recognize that there are individuals within that cohort who are at high risk and yet are healthy enough to benefit from screening. And in those individuals, you can consider screening. We even left a risk threshold based on a particular risk calculator, highlighted that those may not be insurance-covered screens. And we said for others, those who don't meet criteria number one, those who aren't deemed to be high risk, you should not be screening them. And we also recommended for those that have quite severe comorbidities that would limit their ability to tolerate an evaluation of a screen-detected finding or treatment of a screen-detected early lung cancer, that you should not screen those individuals. In our remark, we recognized that it is sometimes difficult to define who's at too high a risk from their comorbid disease to exclude them from screening. And then finally, if someone presents to you who has symptoms of lung cancer, don't bother with screening them. It doesn't matter if they're eligible or not. Evaluate them for their symptom. So what evidence is coming our way that may change our guidance? The Nelson trial, an approximately 15,000 person trial based in the Netherlands, was reported in abstract form about a year ago, and we're anxiously waiting the full publication. In abstract form, they showed a very large decrease in the number of stage 4 lung cancers in their screening arm, even larger than in the NLST, and a very large increase in the portion of cancers that were stage 1, even larger than the NLST. They reported mortality reduction that was a little bit higher than that in the NLST, particularly in women. We suspect when the full data is reported that we will incorporate that into the evidence and potentially adjust our guidelines. The next area was identifying a nodule on a scan. What nodule are you going to call positive? In the National Lung Screening Trial, any nodule 4 millimeters or above led to additional evaluation. Currently, most programs are using Lungrad's criteria, which identify the nodule at 6 millimeters or above. At the time of our guideline, there was evidence to suggest what the trade-off of that increase in size would be. You're going to delay the diagnosis of some cancers, and you're going to minimize the number of scans for false positives that you find. Those that were delayed tended to still be stage 1 cancers when followed a year later. So that highlighted answers to the guideline that we provided for what size nodule to call positive, but also highlighted how important it was for compliance with annual screening. So our recommendation was that screening programs define what constitutes a positive test on the low-dose CT for solid and part solid nodules, and we gave a threshold of either 4, 5, or 6, that the evidence wasn't strong enough to favor one versus the other. We defined this as average of short and long axes, and it was the solid component of subsolid nodules. There is some more evidence that's come out, unlikely to change that guidance, but it looked at the NLST negatives that actually had a nodule, so nodules smaller than 4 millimeters in size. And when followed over time, a little over 1% of all of the lung cancers in the study started as a nodule that was read as negative, even though it was present. The delay was almost 2 years to diagnosis, and about 3/4 or so of them were still in stage 1. That's some of the newer evidence, but unlikely to dramatically change our recommendation. Highlighting the fact that bumping the size only works if people are compliant with screening, We had a recommendation suggesting that programs develop strategies to maximize compliance with annual screening. I use the word recommendation. This is actually a consensus-based statement, not enough evidence. There is some evidence to suggest how to improve adherence. Here, the initiation of a nurse navigator in a program led to a big bump in adherence. Here, a simple reminder from either the primary care provider or nurse navigator led to an increase in adherence. No reminder, nobody comes. Recommendation number 8, we suggest that low-dose CT screening programs develop a comprehensive approach to lung nodule management. And this is really the key to both the benefit and harm. This was also an ungraded consensus-based statement. CHEST is updating its lung nodule guidelines, and we would certainly refer to those within screening for guidance in screening programs. The overdiagnosis tends to occur in our subsolid nodules, so we also left a recommendation or a consensus-based statement suggesting that low-dose CT screening programs develop strategies to minimize overtreatment of potentially indolent lung cancers. Shared decision-making is mandated by Medicare. At the time of the production of these guidelines, Medicare already described what should be included in those shared decision-making visits, including the use of a decision aid. We had some evidence suggesting that shared decision-making can increase knowledge of eligibility, of benefits and harms, and that increase wanes over time. So we had a consensus-based statement suggesting that screening programs develop strategies to provide effective counseling and shared decision-making visits prior to performing the low-dose CT. We recognize that some programs are centralized, where a program provider will have those conversations. And in decentralized programs, we said it's up to the program to provide support for the ordering providers to be able to conduct those visits. There is some evidence suggesting more intense guidance helps our patients. Here, a film and a booklet versus a booklet alone. There was a greater increase in knowledge with the more intense education of our patients, and about 2/3 of them felt the more intense information helped them make a decision in keeping with their values. The final recommendations I'll review with you have to do with other findings. The scan looks at the heart, the lungs, the thyroid, even the adrenals and kidney. And so many other findings are reported, anywhere from 40 to 90%. Fewer of them lead to further investigations and far fewer to any invasive procedures. So we produced a table suggesting some of the other findings that were not clinically relevant and shouldn't lead to investigations, others that might, and others that should. And our consensus-based statement was that we suggest that your programs develop strategies to guide the management of non-nodule findings, and that this is prevalent enough that a high-quality screening program really needs to have a plan in place to either manage those or to guide the ordering provider on how to manage those findings. There has been a lot of evidence since then about the kinds of the findings. The one that's maybe raised the level of evidence further is the interstitial lung abnormalities are talked about a whole lot. And in this particular study, those that looked fibrotic on the initial scan were progressed over the following 2-year period about 1/3 of the time. Those that weren't fibrotic, much less commonly. So that's a bit of a whirlwind tour of the lung cancer screening guidelines. I very quickly reviewed the evidence that was available for some of our key guidance and highlighted some of the areas where additional evidence is present that might shape our guidelines over time. Thanks again for the invitation.
Thank you.